He doesn't count. Hey. Just going to talk to you guys a moment. Are we recording this? Yes. I didn't do a formal thing, but tell me when we're ready, Paul. Okay. Okay. I was just going to take a minute of your guys' time to talk to you about a few things coming our way. And we all know that the 15th of this month we're slated to have our new CT scanner. So, and the first week of June we're slated to get surveyed and JACO surveyed to be a primary stroke center. So this is awesome for our community. I'll tell you a few minutes just about some of our capabilities and what we're going to do, and I think a lot of you guys know that. The CT scanner coming in was a much bigger production than we thought it was going to be. When we decided it was going to come in, we didn't quite realize that we would have to rebuild the entire infrastructure of the roof and the CT room and the air conditioning units, and just because the sheer cooling capacity required for the new scanner was different than the old scanners. So what we thought was going to initially take a couple weeks ended up being several months. And that was to replace the air conditioning units. And you said, oh, well, we have to replace those. Well, they're so heavy we have to reinforce the roof. So then you have to alter the duct system, the electrical system. So that's part of what's brought this into a longer cycle than we anticipated. But our scanner is going to have CT perfusion capabilities, CTA capabilities, and it is, next to Fort Sanders Regional, the best in the system out there. So what that's going to allow us to do is do all the advanced imaging that regional can do. What we're going to lack in that capacity is, obviously the neurointerventionalist. So if you say, what's the difference between a primary stroke center and a comprehensive stroke center? So it's the specialists that are there. So right now we have a really good telemedicine process with the neurohospitalists, and I think you guys have seen some of that in action. So we're actually going to be able to keep TPA patients in our hospital. We're going to be able to manage them. So rather than before we were talking about a ship all process, now we're actually going to be keeping people. And the process is going to involve a lot of what we do. You guys are going to call ahead. As first responders, you may call EMS. We're going to call ahead. If you guys can give us notice, and you use primarily the Cincinnati stroke scale, right, Travis? Do you use the Los Angeles at all, or just Cincinnati? So Rural Metro is doing the Los Angeles and the Cincinnati. But you're going to go say this is, you're going to say this is a possible stroke. You're going to come in. We're going to wheel them in, go straight to CT scanner. The doctor may eye on the flyby, right to CT scanner. We'll determine at that point if they need a CTA or not. Look at that, come back. Well, the neurohospitalists review the scans as well as the radiologist. We'll determine relatively quickly in that process if they're a neurointerventional candidate or not, and whether to start TPA or not. So I think it's going to be a streamlined, good process for our community. So, did you have a question? Via telemedicine. So they're going to be, so the guys that are in charge of this are truly phenomenal at what they do. They're fellowship trained. So Shamir Haji, he's from Vancouver. He is a hockey guy, so he's a Canadian. But Shamir, is Hopkins, fellowship trained, and Mayo Clinic residency trained. These guys are cutting edge, top-notch group. So why did Loudon get these capabilities? I'm going to tell you, we've been kind of right at the forefront of a lot of this. I sit on the neuroservice line and I kind of co-chair it. So I think we've gotten a little extra attention from Covenant for that. And we are the first ones in the system to go live with, we're going to keep our TPA patients. We have a really tight partnership with the Comprehensive Center. So I anticipate us keeping our own. Now, in regards to that, there are going to be people that we ship. And there'll be specific criteria, and that'll have to do with the stroke scale, how severe it is, what their comorbid conditions are, what their risks of bleeding are. And those are going to be the people. So what we don't want to keep is people that would be better served at the Comprehensive Center. So we put a lot of thought into this criteria, and I think they're going to evolve a little bit. So I can tell you right now they're going to stand as an NIH stroke scale greater than 10, which was one key component. We had talked about the ability to control their blood pressure. So if you give them TPA, you have to be able to manage their blood pressure. And that's part of what you guys do. So the patients that aren't going to be kept at our facility are going to go to the Comprehensive Stroke Center, which will be Fort Sanders. So they're not going to go to Park West. They're going to go to Fort Sanders. So the two people that are going to go, or the two groups of patients that we are going to still transfer, are the neurointerventional candidates and the people that meet kind of a subset of criteria that are high risk to bleed. And then if that's the case, we want them at the place that has a neurosurgery consultant. So most of them we're going to keep. Now in regards to that, I brought some forms up that we're going to ask that you fill out, and that has to do with our time windows. So you guys all know our stroke time window, and let me give you a little basic stuff, and I know we're relatively rushed, but so traditionally we said you have 3 hours from onset of symptoms. And that was kind of extended out to 4.5 hours. I think you guys are aware of that. And that was extended out to 4.5 hours. Well, with neurointervention, there are a lot of strokes that are extended out to 12 hours. We're, as time goes on, getting more inclusive, not less inclusive, of the people that we can intervene in and improve their outcomes. So looking up here, we have a Tpa Flow Sheet. And has everybody seen this or not? Okay, so everybody has. So the parts that, Paul, if you can scroll down to all the way down to number 9, number 12. So you're not going to go beyond 12. All that involves the neurointerventional aspects. So bleeding problem, groin assessment, pulses distally. You're not going to do that. But 1 through 11, if they receive TPA, we're going to have you do. And 1 through 11 is a modified NIH stroke scale. And it's every 15 minutes in the first, if we go up here, 2 hours. In the first 2 hours, it's every 15 minutes. I know that says 2.5, but if you look over here, it'll say at the 2 hour and then the 2.5 hour. So every 15 minutes, you're going to do that. Now, you're most likely not going to be picking the patient up till somewhere around the 1 hour mark when we've started the TPA. Our goal and objective is to give them TPA within 60 minutes of their arrival to the emergency department. So within 60 minutes. Now, at the 1 hour mark when you're picking them up, we also have a goal to transfer them out within 2 hours. So any time before 2 hours is, and that's a JCO mandated and kind of assessed goal. So we're going to try to get them out before 2 hours, and that's why I brought up the 15-minute timeline. So you're going to do a modified NIH stroke scale, and I'll show you what all those criteria are, but they're basically, can they lift their right arm versus gravity or not? Does it drop? Does it stay up? Then level of consciousness. Really simple things, and at the last page, you're going to see kind of what they are. So then as you go up, go ahead and go to the next page, Paul. As you go up at the 3 hour mark, then it's every 30 minutes till you get to 6 hours, and at 6 hours, it's every hour. So it'll say that right on the sheet, same form. And then if you go to the last page, and this is on the back of every page. So on the back of each of those pages, you'll have the actual assessment and how to grade it. So the reason we want them graded is if they're on an NIH or their modified NIH is worsening, it may be a reason to reverse the TPA. So if you're en route and all of a sudden you're getting higher and higher scores, so they started out, they were a 7, now they're a 9, now they're a 10 or 11 when you get to Fort Sanders. They want to know that because they're going to immediately repeat a CT scan. And they're going to consider reversing the TPA because we're worried about, did the person have a hemorrhage? So the other parameter in that is blood pressure control. And we have a hypertensive protocol. And on here it gives the parameters for what we want to keep. And basically it's a systolic 185 and a diastolic 105. And then you're going to give a single dose or 2 doses of hydralazine or labetalol. And that's what's carried. So could you bring me, the other form. This is the form just so you can see. If you look over here, the neuro check, 2 hours that I was talking about, 30 minutes every 6 hours, and their vital signs and where to maintain their blood pressure. So, and I just put that up there because those are the orders that we kind of manage by, so you guys can understand them. So, are there any questions on stroke? I just thought I'd give you an update on it. It is more than you knew, or okay, good.
But I understand your guys' goal was actually keep TPA.
Right. It's exciting stuff. So we are going to have, this community has just gained a great resource. I mean, we have the capabilities. So why perfusion scanners help us so much is they're starting to do away with these time windows, these artificial windows. They're actually, what a perfusion scanner does, and this is, if you guys don't understand, what it's going to do is it's going to say what area of the brain is salvageable if we reverse it. So we're going to go through and say, will TPA benefit them or not? And it's going to basically say, yes, can make a big difference, or no, it's not going to make a difference. Don't put the patient at risk by giving them TPA. So we have great things. I'm really excited, if you can't tell. I actually am. The only other bit of news I have is we're going to be doing some morbidity and mortality conferences. And I talked to Paul briefly about this in the neuro service line. And EMS personnel, initially, it's going to probably just be a select small number of people to go and to sit on it. I think it's going to be really high yield. And a portion of it is aimed at first responders and EMS. So, in that first part, what we're going to do is we're going to give case presentations. We had our first one. It was just amongst physician staff. But it's very first responder focused a little bit, and there's a part of that. And that's kind of the whole ER piece I'm in charge of. So those presentations, I'll be giving the first part, and I am going to focus in on lessons learned, ways to improve care. And we identified some issues even in our first case. And we looked at things like GCS being used. And they're like, okay, well, the GCS was this. And that was the neuro assessment. And we're like, well, you know, a GCS of 9 doesn't really tell me anything. Can they raise their right arm? Can't they? I mean, did they open their eyes or not? And it didn't guide us at all. And those were some lessons we're kind of starting to learn through this process to help us out. So, any other questions? No? Okay, thank you for your time.